Sachin sir, can we start?
Yes, let us start. Good
Okay.
evening, everyone. Madam, you want to introduce?
Yeah, yes,
Yeah,
definitely, sir.
go ahead.
So, preoperative clearance in hematology is a very, very, very important topic because as family medicine practitioners, now you are seen everywhere in nursing homes, you are seen in secondary and tertiary care hospitals, and even in quaternary care. You are called to give fitness for simple surgeries like cataracts or even complex surgeries. So I remember my days about 12 years, 13 years back. I was working in Lions Eye Hospital for giving fitness for cataract surgeries and other ocular surgeries. So I had a patient whose platelet count was 65,000. So I was very jittery to give. And even after consulting my hematologist, I gave fitness, but I waited throughout the surgery and 2 hours post-op until patient left the hospital. So I think with this HEMAT course running, it has given us a lot of confidence because day before yesterday, Sachin sir was asked to see a case. He also remembers a young chap with germ cell tumor, highly undifferentiated, who suddenly had crashed his platelets. It was around 15,000. But because of his regular training, which he had told us, I could confidently, say that arrange 6 STPs or arrange one SDP or 6 RDPs and assess that patient is hemodynamically stable, though he was quite a little breathless, ruled out any bleeding diathesis in him, and then asked for SIRS reference. So that is the confidence of what we are gaining. I'm sure all of you can share your stories, and hence this topic is of great importance in our day-to-day practice. And to learn more about this, we have Dr. Sachin, the subject experts, who will give us wonderful insights regarding the same. Over to you, Sachin, sir.
Thank you, Dr. Sami. I did not realize that you had given the suggestions for the SDP, and I'm so happy that you did. It just shows that whatever this course is doing is helping us in practice. The
It's
goal
been
is
a very impactful course, sir. I'm sure all the participants will agree. So even on a holiday, you have already 35 plus participants on time. Over to you, sir.
thank you, everyone. Let's see what we are going to discuss in this talk, and essentially we will be looking at most of the common problems that you would encounter in patients who are admitted for surgery. And preoperatively, almost every patient now has a complete blood count, LFT, RFT, PTA, PTT, and which is a good thing. And most of these now come as packages when patients go to any lab. And in that, you may find that they have either high or low counts, or the coagulation parameters are abnormal. Now, at the outset, I want to tell you something that when we look at coagulation parameters, we look at the platelet count, bleeding time, PT, and APTT. And this kind of gives us an overall view of coagulation. Most of our labs and most of our colleagues are still doing clotting time. I want to reiterate that that's an outdated test. It's not sensitive enough. And CT has been replaced by PT and APTT. Um, Beyond preoperative, we'll also be looking at the scenarios where you would be consulted for an issue in hematology, either something that has arisen intra-op or that has come up post-operative. And usually this is some kind of bleeding. So either the surgeon or the anesthetist may say that there is unusual bleeding, or post-operatively, the surgeon might call you saying, intra-op, the bleeding was not too much, uh, uh, and pre-operative blood tests were okay. Uh, Post-op, I had good primary hemostasis, but then post-op day 2 or 3, there is excess blood in the drain, and what to do, right? So that's kind of a recurrent bleeding or something that happens post-op. There will also be a scenario called massive transfusion, and I'm sure Ashish has touched upon this, or he will do that in his upcoming talk, where what happens is you are called from the operation theater or surgical ICU or post-op surgical ward, saying there is a patient who had a lot of bleeding intra-op, and now the platelets are low or PT ability is prolonged. And at that time, you will think, yeah, maybe this is because of massive transfusion. What happens in massive transfusion is essentially the patient has had a intra-op hemorrhage, or they come with a road traffic accident, or postpartum bleeding typically. In that case, the surgeons, the emergency department, our ICU colleagues and anesthetists, they have to give blood. And we have about 70 ml per kg of blood in our body. So, 70 kg adult or a 60 kg adult would have about 3.5 liters of blood. So what that means is if I have 3.5 liters of blood, for example, then when somebody gives me IV fluids, and if I bled a lot, if I get 3, 4, 5 packets of red cells, right? Then 4 packets of red cell would mean about 1 to 1.5 liters of packed red cell. So imagine 1.5 liters of packed red cell going in my blood and diluting out my platelets and coagulation factors. So that is what happens in a massive transfusion, right? And we'll touch upon that. What we will not be discussing today is thromboprophylaxis, which, thankfully, because of a lot of research and a lot of CMEs that have happened with our surgical colleagues and orthopedic colleagues, nowadays, most of the patients are getting prophylaxis post-op to prevent deep vein thrombosis, right? Any kind of venous thromboembolism. It may be a DVT of the lower limbs or pulmonary embolism, but that is a different topic. It's far more voluminous and best covered in a separate talk, and we will not be talking about thromboprophylaxis. So let's start with the preoperative issues. I want to first tell you some general principles of managing this, and then of course we'll get into the detailing. The general principles are, remember, our job is to try and safely clear the patient for surgery, right? As consultative hematology specialists, as somebody who's been called to clear for surgery, our job is to try and clear the patient for surgery. Provided you feel that there is something very serious and that which needs evaluation before surgery, provided we should clear if the surgery is essential, has to be done immediately and is life-saving. So what I'm telling you is there are two broad scenarios. First of all, our job is to try and clear for surgery and support the surgeon and the anesthetist through the surgery, right? As physicians, we have to support them. On the other hand, if it's better to postpone the surgery because of a major problem, or if the hematologic issue is so severe that surgery would cause more harm than good, right? Then we should be able to alert our surgical teams about that. So whenever I get a call for somebody who's pre-op, and we help a couple of orthopedic hospitals, and our own hospital is a major neurosurgical and ENT unit. So we could get call saying, hey, we have posted somebody for surgery tomorrow, and the hemoglobin is low or platelets are low, etc., etc. I first ask, what's the surgery? When is it planned? Because that tells me how much time I have for evaluation if I need to evaluate. That's the most important thing. So the urgency of surgery. In this, our surgical colleagues can sometimes get cheeky, and they may say, no, 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 it's urgent. I have to do it tonight. But we have to figure out if it's a genuine medical urgency, or, they've posted the patient and they don't want the list to suffer. Hence they want to push, and even in that case we should try our best to clear the patient for surgery. But it's a good idea to understand whether it's a how urgent is the procedure, and is it a medical urgency or an administrative urgency, right? Um, if I'm told, look, it's an elective surgery, don't worry, we have time. And by time, generally, if there is a problem with any, basically hematologic issues are, hemoglobin, WBC platelet, PTA, PT2, essentially. So I may need up to 3 to 4 days, especially if I have to do a bone marrow exam. So for me to get a final report for some patients. So when somebody says elective, for me, if I need to do proper evaluation, I may take 3, 4 days. Okay. So that is what I mean by elective surgery, which can be postponed. Uh, if I have the time, I would evaluate the issue properly and figure out, hey, look, this is something minor. We can correct it. Go ahead with surgery. However, if on my evaluation it turns out, no, 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 this is a major issue. By chance, you have picked up a moderate hemophilia, you have picked up von Willebrand disease, then is a major issue. If you operate this patient without proper preparation, then there's going to be massive intra-op and post-op bleeding, right? So whenever I figure out there's a major hematologic issue, I'll say, hey, look, let's do a complete coagulation workup. Let us arrange enough FFPs, cryoprecipitate, platelet, or coagulation factor concentrate. I mean, today we get factor 8, factor 9, von Willebrand, we get concentrate. So we have to have enough vials. They are expensive. They are not available everywhere. So we need time to arrange the coagulation factor support. So if it's not urgent and if it's a major hematologic issue, I say, hey, look, hold on, I need a week now to arrange everything so that we can take the patient forward. Uh, this is most important because now what is happening is patients will come up to, for example, our orthopedic friends for a knee replacement. And, I'll give you two examples of this. One is a knee replacement for osteoarthritis. And this was a lady, she was about in her early 60s, 10 years ago. And she had knee pain, was diagnosed as osteoarthritis, was being planned for knee surgery. And this orthopedic friend of mine, he said, Sachin, there's this patient and, hemoglobin is low, ESR is high, can you look at it? And I saw her, and ESR high in hematology at that age with bone pain. I thought, well, I have to rule out myeloma. So I looked at the knee X-ray properly, and I found tiny lytic lesions. Now you see, these are tiny lytic lesions which are causing pain. And I thought, hey, this may be a myeloma because of which ESR is high. So I called up my friend. I said, look, boss, we if it's not urgent, can we push this? He said, yeah, 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 don't worry. This is just an elective total knee replacement of the right knee. And he was surprised. And I, of course, sent off our myeloma workup. And he came back from the OT that day and he said, Sachin, let's look at her x-rays again. And then he was stunned because him and his team had missed the lytic lesions. This does not mean he's a bad doctor. Okay. Many times we work with a bias. Patients come to us with a diagnosis and we look at them through the prism of that diagnosis, and whatever makes sense we accept. Yeah, 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 this is osteoarthritis, etc., etc. Whereas for me, because I was biased towards detecting myeloma, I could pick out these tiny lytic lesions. This is also the reason why I tell my team that I hate this term called known case of. Whenever we say known case of, we stop thinking, yeah, yeah, known case of Cox, known case of osteoarthritis. Then everybody says, no, no, known case. And ours is probably one of the few countries where this term is used. Nowhere in the world does anybody say K/C/O, known case of, because that's so dangerous. How do you know? We can say diagnosed to have so and so and planned. Don't say you know everything. Okay. Eventually, that lady turned out to be multiple myeloma, and it turned out that the bone pain was because of myeloma. Because when he looked at it, he said, well, yeah, there is osteoarthritis at that age. But let's treat the myeloma, and her bone pain went off. She did not need a knee replacement. Of course, myeloma is a much worse diagnosis, but at least, we were able to treat her and she's doing well 11 years down the line. However, if there is a major heme issue and your surgical colleagues say, no, this is urgent, I have to go ahead, this is perforated appendix or road traffic accident or intracranial hemorrhage, I have to do it. Then you say, all right, I'm not going to stop you. Surgery is life-saving. It's urgent. We'll do minimal tests and we're going to clear you for emergency surgery. When we clear the patient for emergency surgery without a proper diagnosis, you have to say, well, we are clearing with moderate or high risk of surgery. It may be a risk of bleeding, maybe a risk of infections, whatever. And we will also help the surgical team by saying, all right, buddy, you want to take over? Let me arrange enough PRBCs, platelets, FFP for you, and we clear for surgery. And post-operatively, we will do a more detailed evaluation. Now let's get into specifics. What about hemoglobin? What if you're called and the patient's hemoglobin is high or low? So now I am not going to talk about elective surgeries so much now because that's part of our routine hematology knowledge. Let's start looking at urgent surgeries. Somebody who has high hemoglobin or platelets, and your colleagues say, no, this is urgent, we have to take up. You say, yeah, let me do some minimal tests. And in a patient with anemia, I want to take a preoperative sample for iron deficiency B12 folate. Okay. At this point, don't forget to send LDH so that you don't miss hemolytic anemia. You don't miss B12 deficiency, iron, folate, etc. Also, do not forget LFT creatinine. See, somebody coming with low hemoglobin might actually be due to cirrhosis, microscopic, GI bleeding, might be CKD. You won't believe how many patients are diagnosed with CKD because they have low hemoglobin, right? And the creatinine is done. So whenever somebody has any major problem, do a system review. Ensure that you are not missing something else that could actually be presenting as anemia. Send off these tests. You don't, it's an emergency surgery. You don't really have to wait for the results. Ensure that there are enough PRBCs and you clear for surgery. Ensure that there's enough packed red blood cell, even post-op, because if somebody has hemolytic anemia or hemorrhage related anemia, and they may need blood post-op as well. So you have to talk to blood bank and arrange enough units. There is one thing that I want to tell you here, that sometimes what happens is when patients come for surgery, their hemoglobin may be within the normal range. So it may be 10.5, 11, and immediate post-op, the HB may be 9 grams, right? And the surgeon may say, there wasn't much bleeding. I don't know why 10.5 or 11 grams hemoglobin has dropped to 8 or 9, 1 to 2 grams drop. 1 gram is equal to 1 unit of blood, right? That's almost 450 ml of blood. She's not had 900 ml of blood loss. I don't know why it has dropped. Many times in our environment, because we are, a hot country, right? Temperatures are higher in our country. Uh, what happens is when the patient gets admitted for surgery, elective or urgent, they may be dehydrated and the pre-op hemoglobin may be hemoconcentrated. But then intra-op, post-op, when they get IV fluids, they get their normal salines, ringer lactate, etc., the blood gets diluted. And that's where the hemoglobin may drop because of hemoconcentration from by 1 or 2 grams. Okay. Generally, that is the drop. So for example, 12 grams cannot drop to 5 grams. That can't be hemodilution. That means something is happening. But just 1 or 2 grams without any evidence of hemolysis, without any major blood loss might be because of hemoconcentration. So that's a differential diagnosis that you have to be aware of. Once you've cleared the patient, don't forget to see the patient post-op. The reports that you've sent pre-op, make a diagnosis, iron deficiency, B12, folate, hemolysis, abnormal liver, kidney function test, because Otherwise, this patient will get discharged from the surgical site saying, yeah, there was some low hemoglobin and we got one packet blood and we were discharged. We didn't really know what was the cause. So it's our job as physicians to ensure that from our side also we are able to give a diagnosis by following up the tests later and suggesting long-term follow-up or telling the patient, hey, look, you had iron deficiency. Anyways, you've gone through the surgery. Here, take these iron tablets. Come and see me after 2 weeks. So that follow-up is very important. It's not just about clearing for surgery. We have to treat the patient as a whole and not just the number, not just the test report. Now let's come to the other end of the spectrum. What about somebody coming with high hemoglobin 16, 17, 20, 21, right? What do we do? Proceed with surgery. High hemoglobin is not a major issue. Yes, what is most important is that our anesthetist should give enough hydration. We have to ensure that there is no dehydration intra-op and post-op. Somebody with high hemoglobin having dehydration can actually have thrombosis. So sometimes patients with polycythemia um, who don't get properly hydrated and mobilized. And in fact, they may also need some thromboprophylaxis. So you may consider giving them no molecular weight heparin or, even the new DOACs, direct oral anticoagulants, because they have high hemoglobin. They're prone for thrombosis and bleeding. So you have to talk to the surgeon, you have to talk to the anesthetist saying, yeah, go ahead with the surgery, but give enough hydration. Post-op, follow up the hemoglobin. If the hemoglobin is still high, ensure there is, prompt mobilization post-op. We don't want them to be lying in bed recumbent where they can get DVT, right? DVT is caused by stasis. So they should be mobile. Think if there is a very high risk of thrombosis, so in an obese patient with high hemoglobin, diabetes, blood pressure, you might err on the side of giving an aspirin or low molecular weight heparin. So this is, high or low hemoglobin. These are the typical pre-op issues. Let's look at WBC. Whether WBCs are high or low, okay? Whether they're high or low, you have to look at minimum these four things pre-op. So you do a general examination, look at the lymph nodes, cervical, axillary, inguinal. Don't forget the posterior occipital lymph node. So palpate the lymph nodes, liver, spleen, as we have discussed, because these can get enlarged in hematologic malignancies, right? You don't want to miss out a leukemia or lymphoma pre-op. Uh, no WBC, talk to your pathology colleagues, tell them, hey, can you do a peripheral smear and tell me if there are any atypical cells? Do an LDH, because as we have discussed umpteen number of times, LDH is a marker for malignancy, hemolysis, and B12 deficiency, right? And sometimes the low WBC may be due to consumption, excess consumption of WBCs, because they are the soldiers which are fighting infection. So you have to ensure there's no sepsis preceding surgery, etc. Somebody who's had multiple surgeries, road traffic accident, burst abdomen, might actually be having gram-negative bacteremia, and now WBCs have gone down because of excessive consumption. So these are the three, four things that you will check very rapidly clinically, and then you will divide the patients into two. Okay, low WBC patients you will divide into two. If the WBCs are more than 3,000, okay, it's not very bad. If the neutrophil count is more than 1,000 or 1,500, it's not bad. And if the peripheral smear is fine, there are no abnormal cells, all right, then that's a good group of patients. There is the other group of patients where WBCs are very low, 1,000, 500, where the neutrophils are very low, absolute neutrophil count less than 500, where your pathologist says, no, no, there are some abnormal cells in the blood. This is where you are seriously thinking of a marrow issue. Either it's an aplastic anemia or a leukemia or a lymphoma. And if this is happening, you need to go back and tell your surgeon, hey, are you sure this is an urgent surgery? Is this surgery really going to save his life? If they say, no, 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 it's okay. Yeah, I was thinking of burst abdomen, but he's been stable. I don't have to take him up for surgery. You say, okay, great. let me do a quick marrow and try and get a diagnosis. Okay. But if the surgeon says, no, no, I have to take this is a burst abdomen or a bleeder. If I don't take him up for surgery now, he's going to die in the next 6 hours. And you say, yeah, sure, take up for surgery, talk to the family, tell them, look, very high risk. WBCs are low, something may be wrong with the marrow, maybe marrow failure, maybe leukemia, which has actually led to a GI infection. Okay, so now we are coming back to hematologic problems like aplastic anemia, leukemia, which may present with a surgical abdomen, for example, correct? And you say, yeah, but we have to do the surgery quickly. We have to clear with high risk. Sometimes anesthetist says, no, we have to take a consent of death on table. Sure, please do that. Counsel the family. If they agree, take the consent, sign it. Medico legally, you have to be right. Family has to be informed, etc. At that point, what we do is we tell the surgeon, okay, man, you take this patient for surgery. I will come in the OT. Anyways, the patient is under anesthesia. I'll quickly finish off a marrow. So before they start the surgery, I go and I tell the anesthetist, Madam, quick marrow, please don't mind. Surgeon says, yeah, 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 do it off. As soon as they give GA, I turn the patient and do a bone marrow aspirate and biopsy through posterior superior iliac spine, turn the patient again into, whatever is the surgical position and get out of the OT, let the surgeon do his or her work, right? So that's how we deal with low WBC, right? But then there are patients where it's not very bad. WBCs are not very low. Neutrophils are okay. No abnormal cells. Urgent surgery. I'll say, sure, clear for surgery, moderate risk. Again, I'll try to do a marrow in the OT, follow up the reports and treat the hematologic condition. What about high WBC? Absolutely the same thought process. Look for liver, spleen, lymph nodes, peripheral smear, sepsis. See if the high WBC is actually reactive, right? Because of sepsis, there may be the high WBC count with a left shift. Your pathology friends will tell you, and will say, yeah, yeah, there is a left shift, mainly neutrophils. Must be looks like sepsis, no abnormal cells, and then you tell the surgeon, okay, go ahead with surgery. And post-op, I will figure out what it is. I'll do a marrow if required. Or if it was just sepsis and the WBCs recover once the infection is controlled, I don't even have to do a marrow, right? So this is your cleanest patient. So that's why it's in green. I've tried to give a bit of color coding in this talk because this talk is to alert you to particular patient populations who need more aggressive evaluation and treatment. On the other hand, there may be somebody with a high WBC count, looks like a leukemia. Again, you're coming back to this part, right? To ask the surgeon, is this surgery life-saving? This might just be a leukemia coming with GI infection, colitis. In that state, if you operate, they will die because of the surgery. There are patients where they may have leukemia, aplastic anemia, they may come with bad infections, they may come with fungal sinusitis, they may come with, what we call as typhlitis, which is essentially infection of the cecum, appendix, and the ascending colon. In those patients, they look like surgical abdomen, but we should not operate. They are best treated conservatively unless there is a burst abdomen. So if there's burst abdomen, you have to operate with very high risk. Otherwise, you have to treat them conservatively, give them antibiotics, IV fluids, do a bone marrow, get a diagnosis. If the patient says, no, no, this is burst abdomen, I have to operate, you say, sure, but do minimum surgery. And, for that, we will clear with high risk. Again, you can go in the OT and do of a marrow in this patient. So that's hemoglobin WBC. We are coming to platelets, platelets low and platelets high. The same, approach. Low platelets, again, these are the things that we are going to check as we have discussed in the talk on approach to thrombocytopenia. So look for bleeding. Yeah, platelets are low, but is there any bleeding? Is it mucocutaneous, right? So oral cavity, genitourinary, gastrointestinal bleeding. Are there any petechiae, purpurae, or bruises on the skin? So check for mucocutaneous bleeding. How bad is this low platelet, right? And on examination, again, look for lymph nodes, liver, spleen, because as I said, they are enlarged in hematologic malignancies. Call up your pathology friend, ask for a manual platelet count, ensure that this is genuine thrombocytopenia and this is not your pseudo thrombocytopenia. You remember there are two reasons for pseudothrombocytopenia: platelet clumps and giant platelets. So your pathology friends should be able to tell you on peripherals, no, no, there are no platelet clumps, there are no giant platelets. This is genuine pseudothrombocytopenia. Then you check, how are the RBCs? Are they broken? If the RBCs are broken, which means there are schistocytes, which means this could be TTP. TTP, right? Thrombotic thrombocytopenic purpura. Remember, even TTP can present with an acute abdomen or seizures, you know. So rule out these basic things on examination, peripheral smear, do your dengue test, LDH, and do a PT-APTT. Why should we do PT-APTT for somebody with low platelets? Because we don't want to miss a DIC, disseminated intravascular coagulation, which means there are patients where within the vessels, there is diffuse disseminated blood clotting, and that blood clotting is consuming the platelets. So the platelets are low because of consumption, not because of a production issue. First. Second, if somebody has low platelets and they are going for surgery, and you want to prevent intra post-op bleeding, of course you have to give platelet transfusion. But along with that, you also need to give FFP and cryoprecipitate. Because to form a clot, you need platelets and you need your coagulation factors. So if you only give platelets and PT-ability is prolonged and you don't give FFP and cryo, then the clot cannot form, the bleeding will not stop. So if we are doing this basic evaluation for an urgent surgical patient with low platelets. Now, if the platelets are low, but not that low, they are between 1 to 1.5 lakhs or 100,000 to 150,000. So borderline low, peripheral smear looks okay. There are no schistocytes, genuine thrombocytopenia, but very mild. PT-ability is normal. I can clear for surgery and I can say, hey, don't worry, 1 lakh 10,000 platelet. Go ahead. You can check the platelets intra-op and post-op. Keep SDP, RDP ready, clear for surgery. Ensure you follow up the platelet count post-op as well. But they are otherwise fine. This They are otherwise fine. There are no abnormal cells in the smear, no hepatosplenomegaly, PT, hepatitis are normal. In these also, you can clear for an emergency surgery, but definitely ensure that platelets are given pre-op, intra-op, post-op also. You follow up, do a bone marrow exam. You can do the marrow in the OT or immediately in post-op. You can clear with moderate risk if it's an urgent surgery, even when it's 50,000 to a lakh. Post-op, continue to follow. And once somebody's platelets were low, and if they remain low, then post-op, you have to give platelet transfusion for 7 to 10 days. Otherwise, they will have late bleeding. Same thing applies for coagulation. For example, patients with hemophilia, when they undergo surgery, we have to give factor 8 pre-op, intra-op, post-op every day for at least 10 days, right? Depending on how major is the surgery. Minor surgeries, we may stop after 5 days. Intermediate level surgeries, 7 to 10 days. And major surgeries, where there is a lot of tissue damage, you need to correct and transfuse platelets or whatever coagulation factors for 10 to 14 days. Okay. So depending on how major was the surgery, depending on how much is the tissue injury intra-op, you have to give platelets or whatever blood products you want to give for at least 5 days and maybe even up to 14 days. That's important. What about those who have very low platelet counts, 5,000, 8,000, 20,000? And your pathologist says, no, 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 atypical cells on smear, maybe ITP, maybe leukemia. Now, again, we have to ask the surgeon, boss, are you sure the surgery has to be done? This is life-saving surgery. If they say yes, okay, but then, you have to take very high risk consent, maybe death on table consent, very low platelet counts. There can be bleeding. Maybe there's leukemia. There can be infections because of reduced immunity. All right, go ahead, counsel the family, prepare them for bad outcome. Keep enough blood products, platelets, blood, etc. ready. Try to do a marrow intra-op so that you can get a quick report. If the doctor says no, no, surgeon says it's not life-saving, I'm not sure what's happening. You say, all right, great, please wait. Let me do a marrow. Let me figure out why this patient has such low platelet counts. So this is about thrombocytopenia. What about high platelets? High platelets are like high hemoglobin. Yeah, they're not too bad. Sure, do a look for, palpate liver spleen for myeloproliferative disorder, peripheral smear, LDH, ferritin because iron deficiency can cause reactive thrombocytosis, sepsis can cause reactive thrombocytosis. Whether it is reactive or even essential thrombocythemia, it does not matter. You can clear for surgery, but again, alert the anesthetist and the surgeon, hey, look, high platelets, there is a high risk of thrombosis. Ensure you give adequate hydration, prompt post-op mobilization, and don't do the marrow in these patients immediately. Don't do it. Essential thrombocythemia is a chronic disorder. Nothing is going to happen immediately, right? It may be reactive, it may be essential, it doesn't matter. You can wait, let them recover peacefully. 4 to 6 weeks later, if the platelets are still high, when the inflammation due to surgery, the infections, if any, have settled, when the iron deficiency has been corrected, 4 6 weeks later, if the platelets are still high, then evaluate for ET. This is the one condition in hematology where you can really take it easy. You don't have to rush into doing a marrow, and as long as you're going to follow up with the patient, and the patient is going to come back to you. So that's about the cells. Now let's look at coagulation. Um, what what causes intra-op, post-op, that's perioperative bleeding? We were taught, and in fact, when I started my hematology training, right, 21 years ago, we used to say, hey, surgeons, why don't you do PT-APTT for all the patients before you operate? Why? You just interested in operating the patient. You don't do a proper evaluation. And until about 2005 or so, we used to think that no, 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 everybody should get a PT-APTT, right? Of course, complete blood count you should do. Then more and more research came up which showed that actually the determinants of bleeding are very weird. Okay. So perioperative bleeding, significant perioperative bleeding occurs in up to 10% of surgeries in the modern era. Our surgical friends are amazing actually. And the bleeding, the presence of bleeding actually correlates with the surgical skill. Okay. And we have more than enough data that that is the most important part, the technical skill, the tissue friability, the vascular strength, etc., the presence of infection, all that. Okay. And it does not correlate with pre-op PT-APTT and bleeding time. Can you believe it? So now our suggestions have have changed. Our suggestions have changed, and because there is good data that even if the pre-op PT or APTT is borderline prolonged, the patient may or may not bleed. And in fact, abnormal PT-APTT is seen in the same 8 to 10% of patients, and they may or may not bleed. Why does that happen? Why does that happen? Why is it that somebody with a prolonged APTT does not bleed? The reason is coagulation is a very, very complex system. We have a bunch of anticoagulant proteins and we have a bunch of procoagulant proteins. Sometimes what happens is even though one test, that is APTT, for example, is prolonged, the compensatory factors might be less and hence or more, and they may actually overcompensate. So mild derangement in PT-hepatitis pre-op does not predict bleeding. It does not predict bleeding. So how can we screen? How can we prevent bleeding? And that is where and you know, this is absolutely proven by fantastic publications. Okay, great research, data analysis and publication, which says that the most important predictor of bleeding is the history. It's the history. The surgical team, orthopedic team, gynae team, the doctors, consultant, resident doctors, in their pre-op assessment and in the anesthesia pre-op assessment, okay, they should ask, have you ever had bleeding? Have you ever had excessive bleeding after an injury or tooth fall? Are you taking any medicines such as aspirin or ibuprofen, which could predispose you to bleeding? Anybody in your family has a history of excessive or unusual bleeding? If these things are there, then there is a direct correlation with increased perioperative bleeding. Okay. So what we need to do effectively is, and of course, you know, liver and kidney derangement also predisposes to bleeding. So what our recommendation today are, the surgical and anesthesia colleagues have to take a personal past and family history of spontaneous or excessive bleeding. They have to see what medications the patient is on, which, you know, our anesthesia colleagues actually do a pretty good job. They will see if somebody is on aspirin or diclofenac, etc. Sometimes patients may be on LMWH for whatever reason. For example, there may be a lady who's pregnant, who's getting low molecular weight heparin because of recurrent pregnancy loss, right? So we have to figure that out in the history. Patients may be on warfarin, acetylene because they've had a rheumatic heart valve surgery in the past, correct? Um, if they are on these drugs, then you have to talk to the specialty which started. For example, if warfarin or acetylene was started by the cardiac surgeon because of an artificial heart valve, then we have to talk to them. Hey, what should we do? Can we stop it? We can't stop it. If we stop it, how do we cover anticoagulation through the surgery and post-op? We don't want too much bleeding. So you have to talk to the proper specialists. You have to, in these patients, you have to do, of course, complete blood count is for everyone, but in these patients, you have to ensure liver spleen is working and properly, you know, LFT, creat is fine. PTA, PTT you can do in these patients, but you don't have to do PTA, PTT in everyone. All right. So if there is no past or family history of bleeding, somebody is not on any medications which can predispose to bleeding, if the CBC is fine, uh, don't do PTA-PTT before surgery. That's the current recommendation. Yeah, because even if you do, they are not going to predict bleeding. What about the drugs which somebody may be on? How soon should you stop? Well, you know, you will find this on many websites now. This will roughly tell you how soon you have to stop these medicines pre-op. What we typically do is, suppose somebody is on warfarin or say apixaban or rivaroxaban, we stop it according to this chart those many days before, and we put them on low molecular weight heparin. Okay. So if there's a heart valve or for whatever reason they are on, you can't just stop that drug. They may get a fatal clotting, right? So you have to transition from this drug to low molecular weight heparin, because low molecular weight heparin has a predictable half-life. You can stop it, right? And you can reverse it with FFP if you like. So we transition to LMWH 1 or 2 days before the surgery, depending on this chart. If the surgery, whenever the surgery is there, you know, Pre-op, you give once or twice a day low molecular weight heparin. On the day of surgery, we skip the morning dose. Yeah, this is not for heart valve. Okay, this is for other patients. We skip the morning dose. Surgery is done. Post-op, if there is no post-operative bleeding, you can restart heparin 12 hours after surgery and then gradually transition to their original anticoagulant. So that is the standard anticoagulant management during surgery. You stop the drug based on their half-life, change over to low molecular weight heparin well before surgery. Morning of surgery, skip the morning dose of your low molecular weight heparin, enoxaparin or fondaparin, whatever it is. Post-op, if there is no major bleeding, 12 hours later, you can again start low molecular weight heparin and then transition to their usual drug. For a patient who has a prosthetic heart valve, uh, typically we don't manage. We just ask the cardiac surgeon to step in and decide about what to do with the anticoagulation because the patient may get sudden and fatal thrombosis of the valve. So if somebody is getting anticoagulation for a heart valve, we don't touch the patient. We tell the surgeon, follow whatever the cardiac surgeon says. We are not going to deal with this because it's truly, if something happens, the cardiac surgeon has to intervene rapidly, right? So heart valves on prosthetic heart valves on anticoagulation, don't touch them, hand them over to cardiothoracic surgeons. Still, what do you do if a patient comes with an abnormal PT or APDT? Repeat it and repeat it from a different lab, better lab. Like we have discussed, most of the labs do not do PT APDT properly. So get it done in a good lab. Repeat this test. In an emergency surgery, if the surgeon calls you saying, hey, look, I've taken the patient for an emergency LSCS or, road traffic accident or whatever. And just now my resident tells me that the PT is prolonged. The patient is on table. What should I do? We say, all right, no problem. Take 3 or 4, PT tubes full of blood. I mean, full means the appropriate ratio. So 3 to 4 tubes of sodium citrate, we take the sample just before pre-op. We tell the anesthesia, just take these samples and send them to the lab and go ahead with the surgery. Meanwhile, keep all the FFPs and cryos ready. It's an urgent surgery. They have to do it. While the surgery starts, ensure FFPs and cryos are sent because the PT ability is deranged. Appropriate dose as per weight, right? So I'm sure Ashish has told you about 12 to 15 ml per kg of FFP and one cryoprecipitate bag per 10 kg body weight is one dose. So ensure those are sent and the blood products are started while you get these coagulation tubes and you repeat the PT, APTT, you can then, do whatever workup you want. If the APTT is deranged, you can do factor assay, whatever. But you have a pre-transfusion, pre-op sample that you can work on while the emergency surgery continues under FFP cryoprecipitate cover. By then, post-op, you have the workup on these 3, 4 sodium citrate tubes with blood, and then you can get a diagnosis and treat them accordingly. Elective surgery, tell them, hey, hold on. If it's von Willebrand or hemophilia or Bernard's Villiers, you're going to have massive bleeding. Elective surgery, please wait. Let me do a proper coagulation workup, and I'll plan a proper blood product support, and then I will clear. So that's the pre-operative part. We looked at high, low hemoglobin, WBC, platelet, and PTA-PTT range. What about intraop? If there is excessive bleeding, surgeon calls you, anesthesia resident calls you, do your basic test, ask for a history. You will be surprised sometimes somebody with mild hemophilia or von Willebrand, the history may not have been taken by the surgical or the anesthesia team, and they may say, yeah, now they are telling us he has hemophilia. You say, okay, no problem. We will quickly arrange FFP cryo and transfuse it, try to get the old records, etc. We have something called as global test of coagulation that is take that will often help you decide whether to give platelets or FFP or cryo. If that's available in your hospital, you can do that. What about blood transfusion? Well, hemoglobin less than 8 grams is the best bet. There is enough research in critically ill patients in ICU and also in post-op and intra-op scenarios. where there are randomized control trials showing that if you maintain a higher threshold of hemoglobin. So there was a concept that maybe if you maintain hemoglobin about 10, okay, then the tissue healing may be faster, right? Especially in patients who have a cardiac problem, etc. But the randomized control trials did not show a benefit for higher threshold for coagulation. And as of today, the recommendation is hemoglobin should be maintained about 8 to 9 gram percent. If it drops below 8, give PRBC. I'm hoping all of you understand that you should not give whole blood transfusion. Stick to PRBCs, RDP, SDP, FFP, cryo. Avoid whole blood transfusion. There's a whole lot of problems attached to it. Other blood products, like I told you, if you have to give platelets, most of the anesthetists want platelets above a lakh. But for superficial surgeries, sebaceous cyst excision, etc., even 50,000 is fine. At that point in time, you have to talk to your anesthetist and surgeon and figure out what they are comfortable with. If you have to give FFP, then the PT ability has to be deranged by at least 1.5 times normal. Anything less than that, FFP does not help. It's not required. So if the PT or ability is more than 1.5 times normal, sure, consider giving FFP. Give cryo if the fibrinogen is less than 100. However, do not transfuse if there is no bleeding and only the blood tests are abnormal. So if the APTT is three times normal, okay, but there's no bleeding, there's no indication for transfusion. So we need to avoid, we need to educate our surgical anesthesia and ICU colleagues saying, hey, we are not treating a number. Why are you giving? Sometimes in a bleeding patient, even if the platelets are more than 1 or 2 lakh, they will still give platelets, hoping that maybe it will stop bleeding. Well, that is the right practice if you are worried that the platelets are not functioning, which means that the platelet number is good, but the functioning is not okay because the patient is on dual antiplatelet or aspirin. Sure, at that point, you can give platelet transfusion even with a normal platelet. But otherwise, there is no rationale in, just giving, throwing FFP and platelets at a patient, especially if the values are normal and if there is no bleeding. Now, coming to massive transfusion protocol, like I told you, um, we have 70 ml per kg of blood volume. And if a patient loses more than one blood volume, okay, so in a 50 kg adult, it will be 3.5 liters. So if there's more than 3.5 liter of infusion or blood loss within 24 hours, or 50%. That means 1.75 liters blood loss or blood transfusion. 1.75 liters means 4 or 5 PRBCs have gone, some FFP have gone. Then you have replaced, you diluted 50% of the blood within 3 hours. Yeah. So this happens in surgeries with major hemorrhage or road traffic accident, or the bleeding is so rapid that the anesthetist is estimating that more than 150 ml blood loss per minute in an intra-op scenario. These are situations where the replacement that we are giving. So when we give PRBCs, PRBCs don't have coagulation factor. They don't have platelets, right? So along with PRBCs, you have to give platelets and FFP as well, because otherwise the platelets and coagulation factor will get diluted out with just fluids, crystalloid, colloid, or packed red cells. Again, if you think that by giving whole blood we can prevent this, that's not true, because in whole blood within 24 hours, the coagulation factors levels start coming down. So any blood transfusion where one of these three has happened, or more than 6 to 10 packed red cells have been given in a day, you can safely assume that the platelets and coagulation factors have been diluted. They have been diluted. So there can be bleeding now, right? At that point, you have to do CBC, PTA, PTT, but don't wait for the report. If this has happened or if this has happened, along with red cells, you order plasma and platelets also. Okay. So 1, 1, 1. So one RBC, you should give one dose of plasma, FFP, that is 12 to 15 ml per kg. You should give one dose of platelets. For adults, it is 6 to 8 RDPs or 1 SDP. Both are the same. So you have to give red cells, plasma, and platelet in 1:1:1 ratio, because this ratio actually reconstitutes the blood and it resembles whole blood as it is in the body. So that's it for today. The summary is preoperatively for all surgeries, even minor surgeries, do a complete blood count and take a family and past history of bleeding. Okay. For major surgeries, you can do a PT ability bleeding time if you like, especially if there is any past history and if the LFT and creat are deranged. If they are really deranged PT ability pre-op, in an elective surgery, evaluate before you clear for surgery. In an emergency surgery, collect the coagulation samples, send it for testing, clear with high risk, and give appropriate transfusions. What about hemoglobin WBC platelet pre-op? If there is low hemoglobin, take appropriate samples, ferritin, B12, folate, LFT, creat, arrange PRBCs and clear for surgery. I mean, that's very simple. Just give blood and go ahead. But send the right tests before transfusion. High hemoglobin or platelets are the least of our problems. You can clear for surgery, but ensure hydration, mobilization, and if there is high risk for DVT, obese patients, malignancy, etc., then please consider giving thromboprophylaxis with low molecular weight heparin or DOACs post-op. What about high or low WBCs or platelets? Check with your surgical friends. Hey man, this is really low or it's okay. Is the surgery really urgent? Or do I have some time to evaluate thoroughly and clear with moderate or high risk, or can we avoid the surgery? So that's it for today. And as usual, I'll upload the talk on YouTube and also share the question paper with you by tomorrow or so. I'll be happy to take questions.
Sir, thanks for a lovely talk. I just want to discuss one case which happened, and it was very astonishing, in fact, life-saving kind of thing. The patient just came with pain abdomen, and she was not feeling comfortable, and she was saying that I'm having menses, but I'm not comfortable. I'm having too much of gas. Can you hear me, sir?
Yeah, yeah, I can hear you.
Okay. So I said, fine. So I examined her and she was actually having a fullness of abdomen. And I said, it's not, I don't think it is, uh, I'm not convinced. So let's get the CBC blood count since you are having menses, periods. So her hemoglobin came down to 7. So I said, I think this is again not commensurating with your periods. Let's do an ultrasound. And it was a ruptured ectopic pregnancy.
Yeah,
We had to take up for immediate surgery.
yeah,
So the main what I'm saying, just by CBC looking and various and just by so as a physician is being very very knowledgeable, and I really thank you for such elaborate sessions that diagnosis making is now becoming very easy for general physicians also. Forget about the hematologists because it's so I just wanted to apprise you that how that course has helped me out here.
thank you. Thank you, Dr. Manoj. Any other question? Do we have anything in the chat box?
There is one question, sir, in the chat box.
So APTT is mildly prolonged, control is 34, and the test is 52. So that would mean 41, yeah, more than 1.5 times normal. No past history of bleeding. Do we need to give FFP to correct APTT preoperatively? Depends on the urgency of surgery. So again, Dr. Kingsley, if the doctor says, look, I have taken up the patient, you say, yeah, no problem, give FFP and you go ahead. But again, you collect some 3, 4 PT sample, the PT tube, you collect some samples and you send to the coagulation lab. Now, the commonest cause for this is going to be a factor 12 deficiency. Okay. And factor 12 deficiency will increase the APTT, but it does not lead to bleeding. It leads to thrombosis. It's very weird, right? So just because there is prolonged APTT does not mean that there will be bleeding. That's the first thing. So emergency surgery, you know, safety is paramount. Give FFP, go ahead. All right. But collect a sample and send it to coagulation lab to see why is the APTT prolonged. APTT can also be prolonged because of lupus anticoagulant, right? And lupus anticoagulant is again prothrombotic. It will not cause bleeding. Yeah. So just because APTT is prolonged does not mean that there will be bleeding. That is the first part. The second part, for APTT to be prolonged like this, okay, for APT to be prolonged by more than 1.5 times normal, your coagulation factor level has come down below 50%. Okay, so let's even assume that somebody has a liver failure, and because of that, the PT is prolonged, and or APTT. That has happened because your coagulation factor level, which normal is 50 to 150%. So let's say 100 is the center, the 50 to 150% is the normal range. When it goes below 50% is when you will get this kind of prolongation. 50%. I told you we have about 3.5 to 4 liters of blood. In that blood, 60% or so is your plasma. So in 4 liters, you have plasma of more than 2 liters. Now in that 2 liter, if you give 3, 4 FFPs, how much coagulation factor are you going to give? Right? And that is why in large studies, it has been shown that for this kind of prolongation, blindly giving FFP may not help. It may not reduce the APTT. It may not prevent bleeding. So emergency, yes, you want to protect the patient, give FFPs, monitor APTT again, give more if required. But if it's not an emergency, figure out why is the APTT prolonged. Is it lupus? Is it factor 12? What's happening? Or is it von Willebrand disease? Right? And then do a sensible planning for surgery. Okay. Next.
Sir, thank you, sir. Sir, there's a one small doubt in that. We had a patient, actually, it's my relative admitted in St. John's Hospital. So for acute abdominal pain, so they diagnosed as appendicitis. Finally, they did that APTT. APTT, initially it was 100. Then they repeated again, it was 90. So in that case, finally it turned to be lupus positive, APLA is positive. So how to differentiate is the APLA positive APTT prolongation from the factor 12 deficiency APTT prolongation? Is there is any
Fantastic question.
without doing the
Yeah.
TRBB, TR, these things?
Fantastic question. But for that, your hematology lab should know there is a slightly different way of doing PT APTT. What is PT APTT? What is this test? In this test, what we do, and I had slightly alluded to this problem when I gave the talk on coagulation. So you have a PT tube, okay, which has the patient's blood, and suppose I have 2-3 ml of blood. I will spin it in a centrifuge. The RBCs, platelets, and WBC will come to the bottom, and I have the patient plasma. Okay, plasma. Then with a pipette, I remove the plasma, put it in another tube. Now this plasma is supposed to have the coagulation factors and also the both prothrombotic and antithrombotic factors. Okay, but it is not clotting because my PT tube has sodium citrate, and that sodium citrate has absorbed all the calcium. So this is
Yes.
patient plasma without calcium. Correct? If I put calcium, it will clot.
Correct.
Yeah. So how PT APTT is done is I put this in a water bath at 37 degrees. I put the PT reagent, APTT reagent, whatever it is, and I add calcium. Now, I compare this with the plasma of a normal person. which is actually a pooled plasma of some 20-30 people, which has all the coagulation factors. And I measure the PT and the APTT. Now, if my control with the normal pooled plasma says, something like this, 34 seconds. Whereas my patient plasma, I mean, both, I have to add the PT, APTT reagent, calcium, both have to be similar. But this is clotting in 34 seconds, whereas the test plasma is clotting in 52 seconds. This means that my patient plasma is taking longer to clot. Maybe because it does not have the coagulation factors, or there is a anticoagulant which is present. Okay. That anticoagulant may be a lupus anticoagulant. Okay. How do I differentiate what is happening in my patient plasma? At this time, the next step is what is called as half patient plus half control. Half patient plus half control. What we do in this, normally, say for PTAPTT, they are taking, suppose 100 microliter of plasma by a pipette. Okay. Instead of 100, I'll take 50 microliter of patient plasma. Okay. So I've taken 50, so half, only half of patient plasma, and other 50 microliter with a pipette, I've put a normal plasma. So half patient, half control. Now, if this PT or APTT was prolonged because of coagulation factor deficiency, then my control plasma will correct it. Okay. My control plasma will replace the deficient coagulation factor. And with this half patient, half control, my APTT should come down from say 52 to 40. For example, with a partial correction or full correction. But even after putting half control, if my APTT is prolonged, still prolonged to 50, 52, 53, that means my patient plasma itself has some anticoagulant. Okay. So to differentiate, you have to call your lab and say, hey, can you do half patient, half control? If half patient, half control is also prolonged, it's an anticoagulant. If it is correcting partially or fully, it is a factor deficiency. I don't know if this is too confusing. If it is confusing, we can take this separately.
Yes, sir. Understood.
Yeah.
Understood, sir. Thanks. Yes, sir. Yes.
You will.
Sir, what about the significance of eosinophils preoperatively, sir?
Oh, nothing. Just go ahead. Yeah. Go
Yes,
ahead
sir.
and post-op, you figure out what to do.
In the range like a 12 to 15%, nothing, we can go ahead with, sir.
Doesn't matter. It doesn't matter. See, eosinophilia is usually reactive. And for some reason, I have seen patients with rheumatic heart disease having high eosinophil count. I don't know. I have seen this because I worked in a hospital which had a very active pediatric cardiac surgery unit. So you can clear for surgery. Yeah, very high eosinophil count can lead to actually suppression of coagulation. So just do a bleeding time, PT, APTT, and if that's normal, you can clear for surgery. Post-op, you can figure out, do the evaluation for eosinophilia. You don't have to delay the surgery for that.
Sir, in case of hemoglobinopathies, any precautions to be taken, sir, preoperatively?
Yeah, that's a different challenge altogether. So if somebody, the worst hemoglobinopathy, so for example, thalassemia major, they don't make normal blood, you have to keep on giving proper blood. For minor hemoglobinopathy, so spherocytosis or thalassemia minor, their hemoglobin in normal life might be okay, 8, 9, they may not be requiring transfusion, but intra post-op, they may need transfusion because HB may drop, right? And I mean, that's the most important thing. I don't want to go into too many details and confuse, but if they're requiring regular blood, continue that. If they're not requiring, keep PRBCs ready because they may require blood during the surgery or post-op.
Thank you, sir.
You're welcome. So there's a question. So Dr. Pradeep is asking, can APTT screen for APLA? Yeah, absolutely. Dr. Dvijashri is asking, one of the patients having WBC count of 17,000, when I repeat 21,000, neutrophil lymphocyte ratio normal. Past report reveals 13,000 counts 2 years ago, completely asymptomatic. Here I would go by hepatosplenomegaly. And if that is there, I would do an early marrow and try to figure out if there is myeloproliferative neoplasm. If not, no hepatosplenomegaly, you could wait and watch. But if the family is worried, might as well do a marrow and, rule out myeloproliferative neoplasm. Sometimes this can be early CML or early myelofibrosis. We have one more question
Just
in
popped
chat.
up.
Just a
Yeah.
minute. Yeah, just a minute. Uh, So hemoglobin 7 with moderate splenomegaly. Oh, that's a problem. So moderate splenomegaly, hemoglobin 7 can be anything. It can be from hypersplenism due to liver cirrhosis, along with esophageal varicose bleeding. It can be a low-grade lymphoma. So this certainly requires evaluation. Of course, emergency surgery, you can just transfuse and go ahead, but tell the surgeons and anesthetists not to give any steroids because we don't want to miss a hematologic malignancy. Okay, guys. Thank you so much. Bye.
Thank you, sir. Thank you.